Thank you for the invitation. I have no disclosures. So what is pain? It's the unpleasant sensory and emotional experience associated with actual or potential tissue damage. Chronic scrotal pain is defined as bothersome pain in the structures within the scrotum for more than 3 months with significant impact on quality of life. Its yearly cost around 55 million, probably underestimated. 2 to 5% of our new outpatient urology clinics are chronic scrotal pain, 1% of primary clinic visits. In average, patients will see 5 providers before they have a definitive treatment, and it's challenging because we don't have standardized protocols. Chronic pain in general is a shared pain between the patient and shared struggle between the patient and the clinicians. As surgeons, we like to have readily available treatments for straightforward problems. Therefore, it's very important to acknowledge the condition and the impact on quality of life. Try to understand the pain phenotype and formulate a management plan accordingly. When you see that on your clinic list, you have a chronic patient pain, you always take probably your sigh, but I think it's very important to take a clinical timeout before you go to the encounter, have a positive attitude, and try to take a focused history and perform a multidimensional approach assessment. I'm talking here to an experienced audience, so we take a very full history of pain from all aspects, ask all about associated symptoms in terms of FLUTS, pelvic pain, constitutional symptoms, musculoskeletal, sexual history, and physical activity. In physical exam, we want to look for identifiable reversible causes, mainly looking for the abdomen for hernias, aneurysm, masses, look for stones, musculoskeletal pain in terms of trigger points, limbs, neuralgia, GU exam looking for tenderness, masses, varicocele, and hydrocele, and do a DRE looking for anal tone, prostate, and pelvic floor muscle. Adjunctive test based on your assessment, urinalysis, cultures, CBC, PMP, and STI panel. Imaging studies, we can start with a scrotal ultrasound. If we have any musculoskeletal symptoms, we can do X-rays, CT for stones and aneurysms. If you think about prostate issues, you can do an MRI pelvis. If it's MSK, you ask for a soft tissue read. And if we think about herniated disc or nerve compression, we'll do MRI spine. It's a very complex neuroanatomy. When we talk about chronic scrotal pain in the realm of pelvic pain, somatic and autonomic neuro overlap. Most of the nerves in the spermatic cord run around the periadventitia of the vas, about 80%, about 15% in the spermatic fascia, and the rest with different parts of the scrotum. It's very important to remember that the posterior aspect of the scrotum is innervated by the peroneal branches of the pudendal nerve. Also, it's very important to understand the normal physiology of pain, which is transduction, we have conversion of a noxious stimuli into electrical energy, then transmission of the electrical stimulus sent to the dorsal horn in the spinal cord, then modulation is either inhibition or amplification, and then perception, which is the conscious awareness of pain as a culmination of the previous processes in the context of the individual's experience. Pain is different for each one of us. Abnormal pain transmission is when we have, you can see here that the blue line is a normal pain response. Abnormal pain response, when you have less intense stimulus causing pain, we call that hyperalgesia, or non-painful stimuli causing pain, we call that allodynia. Again, as you can hear here, normal sensation, you have a nociceptor stimulated, we have pain. Mechanoceptor stimulated, we feel touch. In central sensitization, we have stimulation of the nociceptor resulting in severe pain, hyperalgesia, and non-painful stimuli resulting in pain, we call that allodynia. So we go, in chronic pain, we go from the linear pathway of acute pain into a vicious circle of central sensitization, modulation, perception with no stimulus. We also have to bear in mind, whenever you see a chronic scrotal pain, even if it's labeled as chronic, you have to rule acute causes, whether it's your initial or repeated assessment. We have a very long list of differential diagnoses, and in 50% is idiopathic. I like this European guidelines, classification of chronic pelvic pain, including scrotal pain, based on axes, is very important for the reason that they provided multiple beneficial and good definitions, and most importantly, in my opinion, is the explanation of the phenotyping of pain and the assessment that follows. This is from a good paper from Dr. Ziegelman and Levine. You can see here that we start with assessment of scrotal pain, rule out acute causes, and then an extra scrotal etiologies. Then we do a pelvic exam, DRE, urine analysis, scrotal ultrasound. If it's idiopathic, you can offer a spermatic cord block. If there is improvement more than 50%, then you can consider denervation. or just repeat the blocks. Otherwise, if there's no improvement, then you can consider medical therapies. This is from FECSM website. We can see here can start with conservative management, do spermatic cord blocks. If there's improvement, denervation, orchiectomy in selected cases, high failure rate. Appendectomy for very selected patients, higher success rate. I'll take that with, with really, with very careful selection of patients. And for post-vasectomy pain, we can denervate or reverse. So if we go in details of medical therapy, we do all the scrotal support, SIDS path, the over-counter analgesia. Then we can use pregabalin, gabapentin, amitriptyline, your good friend pelvic floor physiotherapist, and referral to pain medicine. Spermatic cord blocks are very good because they block the peripheral stimulation. They can be diagnostic and therapeutic. If you have pain improvement for more than 4 hours or reduction in symptoms for more than 50%, then you can consider denervation or just repeat the blocks as needed. In terms of technique, you can use your preference choice of local anesthetic with steroids, or Exparel if it's available to you. Mainly you want to go around the pubic tubercle, or if you want to have a more modified, effective approach, you can go periadventitial circumferentially around the vas and around the external inguinal ring for more effective blocks. Denervation is also good in refractory cases, up to 73% resolution. Bear in mind, patients who have pelvic floor spasms, usually their failure rate is much higher, about 50%. Denervation is like a radical varicocele. You remove everything, you end up with the vas, the spermatic vessels, lymphatics to avoid a hydrocele. In primary epididymal pain, we can do the same pathway, and appendectomy in selected cases. Post-vasectomy pain probably needs surgery in 1 to 2% of patients after 2 years usually of treatment. You can do the same thing of medical therapy blocks and denervation. Vas reversal is supported by guidelines. If it's not covered by insurance or the patient wants to maintain their contraceptive status, then we can do denervation. If nothing works, we can send them to our pain medicine specialist. They can do all sorts of nerve blocks, radiofrequency ablations, and in addition to using neurostimulation. Let's say they went to the pain medicine doctors and still they're not improving. At that point, sometimes nothing works. We have to educate the patient and manage their expectations, consider referral to psychotherapy, and focus on pain psychotherapy with cognitive behavioral therapy so they can cope with pain. So we still can offer something to these patients. In conclusion, take a clinical timeout before you go for that encounter. Clear your mind, take a deep breath, go with a positive attitude. I can help that patient. Sometimes just acknowledging the condition will help the patient. It's very important to take a focused history with multidimensional approach assessment, acknowledge the condition and its impact on quality of life, and try to understand the pain phenotype and formulate a management plan accordingly. It's also very important to understand when acute becomes chronic and the vicious circle of chronic pain without a stimulus. So sometimes you're not going to find anything. Have a multidisciplinary team, collaborate with pain medicine, pelvic physiotherapy, and psychotherapy. Identify the acute scrotal conditions, structural reversal primary scrotal pathology, rule out the extrascrotal conditions and causes for referred pain. Medical therapy, in summary, is scrotal support, over-the-counter analgesia, and try to avoid narcotics. You can use gabapentin, pregabalin, and amitriptyline. Spermatic cord blocks is your friend, is diagnostic and therapeutic. If it works with improvement of symptoms for more than 4 hours or reduction in symptoms about 50%, then you can consider denervation. Patient selection is very important. Counsel patients, manage expectations. Denervation can improve pain in up to 73% of patients with refractory idiopathic pain. If patient had pelvic floor spasms or pelvic floor tense muscles, usually the failure rate is about 50%. For post-vasectomy pain, it's effective. Vas reversals are effective. Is an effective option for post-vasectomy pain. If not covered by insurance or the patient wants to maintain their contraception status, consider denervation. I think what we can manage differently mostly is us, our approach to it, and trying to be positive and try to help the patients with all the means that we have and collaborate with other colleagues. And thank you very much.